Okay. Good afternoon, everyone. As people trickle in, I'm going to present today's Grand Round speaker. So it's my distinct pleasure today to introduce Iman Osman, who came up here to speak to us from NYU, where she's been since 2000, after she finished her fellowship in medical oncology at Sloan Kettering. So Iman, to many people in the melanoma field, is a goddess or a mentor or someone whose example we'd like to follow. She was recruited to NYU to actually build up the melanoma unit, and with very little resources, she went from a tiny little, well, it was maybe a big dermatology operation, but very little translational research operation, to a system where they have multiple R01s, MPI grants, et cetera, and they're doing really lovely cutting edge research, mostly translational, and Iman's going to share some of those results with us today. She's also an amazing mentor. She's the Associate Dean at NYU for Translational Research and has raised a large number of translational research faculty and fellows over the years. One of them even came to us. She brought us our very own Sarah Weiss. And for that, we thank you. And we thank you very much for coming. We look forward to your talk.
Thank you. So it's working? Yes. Okay. Thank you for the introduction, Harriet. Thank you for the invitation. So I have no conflicts of interest. So the outlines, I decided to give you a couple of slides of what does this mean, being an Associate Dean of Translational Research. I'm an Egyptian, so history is very important for us. So I wanted to give you one slide about the history of melanoma program at NYU. And then what I think is the current challenges in treating melanoma patients. And then I'll give you an idea about some of the work we are doing at NYU melanoma program to address some of these challenges. So a couple of years ago, Dr. Daphna Barsagi, the Senior Vice Dean for Research, appointed me as Associate Dean for Translational Research, and she gave me this assignment of facilitate and support translational research across NYU. Big word, but what does this mean? And if you think we all know this, you know that translational research is from bench to bedside and from bedside to bench. But the truth of the matter, we don't really take any of our mice to the bedside. We don't do that at NYU. Maybe you do it here. But anyway, and we don't take any of our patients, you know, that we are taking them today to the animal facility because we are doing translational research. We don't do that. What we do is, and what we think we need to do is that for a discovery in the bench to really make it to the clinical care, we need to see if this is really happening in human specimen, in patient specimen, and to take an observation that we know why melanoma goes to the brain, has strobism to brain. You need to study brain met and try to understand the mechanism. And then in the best case scenario, you have a full circle of something that can be really impactful on patient care. When we talk about patient specimen, it can be blood, it can be tissues, it can be sera, it can be urine, and we have a project also using microbiota in stools, but I didn't think putting a piece of stool here would be very interesting. So what we decided to do, and I did it for melanoma, is to develop what I thought that part of the solution would be to develop a universal mechanism to approach patient at the time of registration, to let them sign a consent to allow using their specimen, whatever the specimen is, and link it to clinical information. And the resources here was basically information resources. So patients are approached at the time of registration. They need to go through the consent in a tablet. The reason why it is a tablet, so it is distinct field, so you can track it. But then you take it from once the patient sign consent in the tablet, it sends the message to HealthShare, which is the OnBase, which is our big gate to all information at NYU, send a message to Epic, send directly a message to lab order to get a research blood, and then interact with another software called LabVantage that checking the OR schedule of tomorrow, matching anybody who's going for OR tomorrow that already signed the consent. So go for pathology grossing room. So the people in the grossing room who are processing for clinical, they know that they need to get a piece on the site for research. And then somebody like Harriet, who's not on the OR or not in pathology, can submit a request, and we give her the tissues, and we give her access to the clinical information. So we did this in place, And since we started, we approached 25,000 patients, 17,000 agreed with a success rate of 70%. And I'm happy with the success rate of 70% because it means that, it means that 30% said no. Because when there was one concern when I started that people say, is it right for the registrar to be the one introducing the idea? And it turned that actually our success rate in melanoma with physician approaching the patient is also 70%. The point I want to make is that you need people to say no. What I'm saying is that if I had a success rate of 90%, I would have challenged myself that maybe everybody's signing without knowing what they are signing. Yes? So this is what we are doing with the universal consent. And I think it's very important in any organization to do it. And the more I was discussing with Harry, the more you do it automatically, the less pressure for you to have more FTEs. So when you have the money, you can use the FTE to do something else other than calling the OR and getting the specimen and things like that. So this is one of the things that I'm responsible for at NYU as Associate Dean. So what is the history of melanoma program? So I told you I'm Egyptian. I care so much about history, maybe because building the pyramid was the last thing we did right. But so Harry said, I was straight at the NCI in Egypt, and then I landed at Memorial and Sloan Kettering. Definitely, they were so different in so many ways, but they were at least there was one thing that's common between NCI in Egypt and Memorial. They are both exclusively cancer center. So when I went to NYU, it was the first time that I started to practice and do research in a medical center, not an exclusive cancer center. And I was recruited by NYU to do translational research in melanoma, and they told me, melanoma is a big center at NYU for so long. Melanoma is a big center at NYU for so long. And one of the things I learned at Memorial, and I learned a lot of things, in only God you trust, other than that, show me your data, whatever this means now for a Memorial. But anyway, so I went to NYU and I said, wait a minute, what does it mean that they have a long history? And then I went through the book of NYU. And guess what? I found that in 1882, there was a skin cancer unit at NYU. And this building is on 23rd and 1st Avenue of New York. This is the VA. This is where I see patients now. It doesn't look like this here. But in 1882, 19th century, there was a skin cancer unit at NYU. And then moving forward in the 1970s, NYU investigator, Dr. Alkoff, was the first one who even recognized that you need to put things on database. They accrued around 12,000 patients. They followed them up for 20 years. They were focusing only on clinical at that time. You know what is this? I was lucky to meet Dr. Koff when I went to NYU. This is the computer in 1972. The computer was the size of a room. And NYU Medical Center didn't have a computer. The fellows needed to take the subway to go to NYU downtown Department of Physics to enter the data in the computer. So this is how a computer looked like in 1972. But I would argue NYU was ahead of the curve at that time. In the first 6 months when I moved to NYU, I tried to find mistake in what they did. I couldn't find any mistake. Moving forward, I was part of I was not there, guy, 1970, and I was not there, 1882, okay? I joined NYU in the 2000 as part of an initiative to reinvent and rekindle the leadership of NYU in melanoma. This was around 2003. Nina Bajraj was at that time, Dr. Anna Pavlik, oncologist, David Polsky, dermatologist, Ras Perman, and Rich Shapiro, our surgeon. This is how we started. We were 6 investigators at that time. In 2007, we had enough critical mass that became part of the Cancer Center as a disease-focused program. And this is how we look like now. Okay, again, talking about history, all what I care about history. And people usually say, there was interleukin or DTIC. But I don't know, Harriet, if you know that in metastatic melanoma in 1967, Hydroxyurea, which is an anti-metabolite, was approved for melanoma. And I wonder how they approve it there. Believe it or not, the FDA had a trial of only 14 patients of melanoma. 3 people responded in combination with radiotherapy. FDA were simple at that time. They approved it in 1967 for treating it in melanoma. DTIC in 1975. At that time, we used to say is 5 to 20% response rate, but anybody in the business knew it's close to 5 than to 20%. Interleukin in 1998, I will not then move forward. And actually, we were lucky because I joined the melanoma field around this time. And then was the targeted therapy, BRAF targeting, MEK, the combination. And all of a sudden, instead of 5 to 10%, here 10%, but they needed to go to be treated in an ICU, you are seeing 50% response rate. The combination is 67% response rate. At the same time, and you are aware, this is what Dr. James Allison got the Nobel Prize this year, targeting CTL4, the Nivo, Bembro, and the combination. And then now you are talking about 20%, but durable response, the combination is around 40%. No, the Nivo around 40%, the combination 60%, and they are responding all of a sudden from 10 and 5 to 50, 60. But let me tell you something a little bit more interesting. So what are I'm sure you saw this zillion times, and I saw zillion times now, okay? Which is that the issue with the BRAF mutation, BRAF targeting is the resistance. So basically, this was a patient in his late 30s. When he started, he already received several lines of treatment. He got the BRAF targeting, okay? And the one in B is showing almost complete disappearance of the skin lesion and then progression. This paper was published in 2011. The senior author was Garaway before he went to industry. And this paper, most of the people show this slide and move on. But actually, if you read this paper carefully, the message was not only this impressive response. Number one, they never claimed that the patient had CR. They said that nearly complete disappearance of the cutaneous lesion. This was at week 15. They say in the paper week 16, the patient start to develop this, and this week 23. So I wouldn't consider it even secondary resistance. It was first primary resistance. But what Garaway and the group did at that time, they had biopsy from the lesion here and biopsy from the lesion here. And what they said in the paper, in the biopsy from the lesion here showed MEK1 mutation. And then they did ex vivo testing of MEK inhibition for this lesion that had MEK mutation, and the ex vivo didn't respond. What Garaway said in 2011 that it's complicated, and that even biopsy the lesion here and you find something does not mean that if you target it you will find solution. And guess what? 7 years later, what he said was true. It's complicated. Right now, there are more than 12 resistance mechanisms of melanoma. When you check, there are 95 clinical trials involving BRAF inhibition in melanoma. I'm unaware, based on what has been published and what I'm reviewing for paper or grant, that you will hear any breakthrough in this area coming soon. I might be wrong. Harriet might be more aware. But 7 years later, still Cell and Nature publishing paper on a different mechanism of resistance. 50% even of the lesion that we are aware, they don't have any of this mechanism. And there is nothing in the combination that's really working that changed the landscape. Okay, and this is a different point, but I don't know, do we need even to discover what did we do for RAS mutant? We don't have anything really for, what we do for RAS in general. But what I'm saying is that there are areas that clearly understudied that is very important. This is my reading of what is going on in the BRAF targeting. What about the immune therapy? So if you look here, we are talking chemotherapy was 5%, targeted therapy, EPI 20, PD1 around 30, 40%. The combination is around 60%. So everybody's talking about, so EPI, PD1, and what? Is it possible to move it even higher? And there are several things. I mean, at NYU, we are working on other things. We know that the IDO inhibitor didn't work. Again, I mean, there are a lot of science, there are a lot of work done there. I'm unaware personally that we will hear very soon about a breakthrough that really moved this beyond this, you know, the combination. And, you know, this is where we are when it comes to this area. So how can we cure melanoma? And when somebody tells you melanoma is deadly disease, this is not true. Melanoma is not a deadly disease. I mean, the people who feel more offended when they hear that is our surgeon, actually. Melanoma stage 1 is curable, okay? So you can make the argument that to cure melanoma, you need to identify it early, prevented it, or, you know, if it is stage 1, it's curable by surgery, except very few, you know, 5% recurrence rate. Localized stage 2, it is curable in good percentage of cases. And I'll talk about something here that now there is a discussion about, can we give adjuvant therapy for stage 2? And I'll tell you why. Resected stage 3, I mean, as an oncologist, we learn very early on that your chances of cure is either early disease, complete resection by surgery, or something that can be responsive to radiotherapy, or the, you know, local control for disease that's not had very low tendency to metastasize. But then the other option of having cure is that if you have, you know, localized disease that has risk of recurrence, and you give them adjuvant therapy, and you increase the chances of long-term survival to the point of cure. This is what happened for breast. It's what happened for any solid tumor that we achieve kind of cure for stage 2 disease or colon cancer, okay? So, but when it comes to metastatic unresectable disease, I think my point is that even with very long-term durable response, we are still talking about durable response. So the cure, in my opinion, if there is a room that we can do something now, because I'm not interested in identifying mechanism number 13 for BRAF, and I don't think we will have a huge impact if at NYU we have clinical trial number 96, okay? Is that, can we identify the people who can benefit from adjuvant therapy, or as the discussion with David, can we identify the patient in stage 3 that you can save them the immune therapy, and can we push even the adjuvant treatment for stage 2? So this is basically the thing we are, we submitted recently a spore, and we think hopefully we will get it. But this was the whole idea of the spore. Can we identify patients? We focus on adjuvant setting, and we focus on immune therapy. One project is microbiota, the stool that I didn't put the picture for. One project with germline. One project is proteomic sera in the blood. And one project is microRNA stage 2. So I'll give you why we thought that is important in adjuvant setting, why we are now focusing a lot of effort on adjuvant setting. Okay, in adjuvant setting, there are 3 big clinical trials in the adjuvant setting. This was, you know, the epi versus placebo. But the problem here is the toxicity. You have 43% on the epi arm and 2% on the placebo arm. But even if you go, even here you say grade 3 and 4, but actually the people who discontinued treatment due to the adverse event was 52%. Okay? And yes, and also this is a study that adjuvant trial, and 2 patients died due to immune-related toxicity. So keep in mind also that if you are giving a treatment that is relatively toxic in advanced disease, when patients don't have the chance of survival, okay, the patient and the physician and everybody will be kind of receptive to that there is a price of toxicity. But when you are going to the adjuvant disease or adjuvant setting, when the patient, they don't have evidence of disease at that time, and they have 50% chance of recurrence, but also they have 50% chance of no recurrence, the argument for toxic treatment, a possible toxic treatment, I think is more challenging. This is the first one. The second one, Okay, the other study, phase 3, placebo versus pembro. Okay, you have 7%. This will look better, 7% versus 0.6. But again, the 13% discontinued treatment because of the of adverse event. The third one, you have this one that compared the Nivo versus Epi, 14 versus 46. I mean, this is by Dr. Weber at NYU now. But again, you have, have more people who had to discontinue treatment due to adverse events. And so we saw that we need to have an assay that can be used in the clinic, that Harriet can determine whether I need to give this patient this or that, or I need to have a prophylactic treatment for the immune therapy. But when you talk about an assay that's used in the clinic, you start to talk about what is the difference between a research assay and clinical assay, okay? This is, how can you make it, how can you make it clear certified? So it doesn't stop at that we are publishing this paper or the Kaplan-Meier is beautiful. How can you take it from being a research assay to a clinical assay? And you think of it, again, as the pyramids. Okay, in discovery, you worry about relative quantification. You can move with moderate specificity. When you get it to the research assay, you need to have high specificity. You need to have low false positive. You need to start developing an internal standard. And you need to have at least moderate to high analytical validation in different cohorts before you think that this can be taken to the clinic. When it comes to the clinic, it needs to have very high validation, analytical validation, and there has to be batch-to-batch quality control. And it turned, and I think David will know this more than anybody else, that to get a clinical assay that Harriet can use, you need to get precise linearity, analytical sensitivity, specificity, accuracy, multiple instruments getting you the same result, quality control. You need to have approval by, one of the governing CAP accreditation to allow you to stratify patients based on assay that we use in the lab. So the thing that we are working on in this direction, which is one of the SPORE project, is that the talking about the toxicity of immune therapy and the autoimmune reaction that happen. I said, okay, so is it possible that the patient, before they start treatment, there are some susceptibility, there is some subclinical level of autoantibodies in patient blood, that when you give them the checkpoint inhibitor, kind of you unleash the response, and this is the reason why they develop this toxicity. So I was looking for, if there is something in the market, and I look at different platform, and I got interested in the CDI lab platform. The reason being is that I found that they were working on their area was primary area of their expertise is systemic autoimmunity. So they develop an assay for systemic lupus, okay? So I said, is it possible that if I'm talking about that patient develop an autoimmune reaction, can I have test something in the sera that can predict their development of autoimmunity? And I decided to start, working with CDI people, a CDI platform. So this is a slide that has a duplicate of 20,000 conformationally intact epitope. It detects both IgM and IgG. It requires very small amount of sera. And when you get to both the discovery, if you get to a selected number of antibodies, you can have a targeted array that can be small number of the epitope, and it can be more cost effective, because if I'm thinking that I want to develop an assay, it has to be something that can be used all over the world, and it can be relatively cheap. Okay, not cheap, but not expensive at least. This is the idea that when you get the discovery, you get this blot, and then you will select some of the things that showed up here, and you independently in different cohort. I can tell you, being in this business for 15 years, I saw a lot of seeing things that is, I witnessed a lot of failures. And yeah, definitely part of me is very critical about this. So I said, before even I want to invest any money or any samples, I want to see, inter-ship variability. Is it possible that when you put, the same sample on the chip, you get different result or the same result? If I send them a sample, okay, because what they do is I send the sample, they do the assay there, but then I do the analysis by our bioinformatics people. So they send me the raw data. So they don't know what I'm sending them, okay? So I had 10 sera, 10 patients, and I did intra-ship reproducibility, and I said, okay, so this is not background noise. At least when you repeat it twice, you are seeing more or less the same result. And then I said, okay, if this is true that this one is detecting really what it needs to detect, I had some patients that I had pre and post anti-CTL4. So I said, if really, this detected, I will see the CTL4 and anti. And guess what? This was a patient, pre and post, and you see that is light up where CTL4 is, okay? So, and it was very consistent. So I said, okay, so it seemed that this is not, again, background noise. So this is the data I started with. So I had, 37 who received CTL4, 27 who received PD-1, anti-PD-1. I had 11 who received the combination. And you will see here, when you see the response to treatment, as you would expect, the combination had the best response. There was no CR in CTL4, less in the anti-PD-1. Toxicity requiring treatment, almost 50% of the people who receive the combination need to have treatment because of, so kind of, while this was a small sample size, it was still kind of reflective of what you expect in the clinic. And basically, we put this, and you will see what was interesting to us that I expected when I started that, if all of that, if you have patients who receive colitis, sorry, not receive colitis. If patient had colitis, okay, and we have what type of toxicity this patient had. If patient has colitis, whether they receive the CTL4 or anti-PD-1 or the combination, you would expect them to have the same or a lot of overlap in their autoantibodies. But it turned out we are seeing a distinct profile in the 3 cohort, okay? And then when you look at the top 15, I can send you, this is published data. You see clear difference between the people here. The difference is between people who had the toxicity compared to the people who didn't have the toxicity. Basically comparing 3 and 4 toxicity to 1 and 2. And when we look at, pathway analysis, is kind of makes sense. TNF alpha signaling, apoptosis, toll-like receptor signaling. And I was talking to David about how important is independent validation. Even with this, while it looked fine, nice, whatever, we said that for real, to really believe in it, we wanted to have independent validation. So basically, but this is again in our, from our bank, we did independent cohort, and specifically in the anti-PD-1, there were 28 overlapping antibody with area under the curve of 95%, meaning predicting toxicity in an independent cohort, selecting only 22 antibodies out of the 20,000 that we started with. But even with this, I mean, you would say, okay, are you pushing it now to clinical assay development? No. All what I'm talking about now is that we think that now it can be tested as part of a clinical trial. This is an adjuvant trial. And the adjuvant trial, Jeff Weber, again, is the PI here. It will be compared the Nivo versus the combination, okay? The Nivo versus the combination of Nevi and Nivo and Epi. And what the company Bristol Myers agreed on is to give us access to the samples, and believe it or not, up to, I mean, I think they already accrued 1,500 of the 2,000 that they plan to. Patients are putting on adjuvant trial. So what I'm saying is that we will test what we are looking at, what we generated in this cohort first before we hand it to a lab that specializes in getting it clear certified. Okay, so this is where we are from this study. I'm an oncologist. I'm a simple-minded clinician, but at least being in this business for a while, I think the first thing that comes to anybody's mind would say, who cares? Maybe it's simple association. You know what I mean? You're having some antibodies that you found in your sample size that is associated with toxicity. So, I mean, how this relate really to what's going on? How can you? So I'm not an immunologist either. So I have Michelle Cosgard, who is a basic immunologist. And I told her, Michelle, can we test in vivo model if this autoantibodies really is contributing, at least in part, okay, to developing of this toxicity? And she said, let me think about it. And then she said, you know, Iman, there is an investigator, Jeff, I don't know how to pronounce his last name, okay, but Jeff, okay? Jeff at Rockefeller, who worked on rheumatoid arthritis. And he developed a model, a mouse model, where he humanized the gamma receptor. So it's not a humanized mouse. We cannot humanize the mouse, but he humanized the gamma receptor. And he published, she told me that he published on that when he got the sera from rheumatoid arthritis patient and put it in this humanized mouse, they develop arthritis. And this allow him to test or to examine some of the things mechanistically. So we reached out to him, and he was generous enough to share with us the mouse. And basically the idea was, I came up with that, okay, Michelle, so can we get the sera from the patient who this patient developed colitis and put it in this immunized mouse and see if the mouse will develop colitis? Looks like James Bond type of things. But guess what? It happened, believe it or not. So basically what this is showing, and it was repeated 3 times before we put it even in the grant to make sure it's true. So basically, this patient, you know, ID 071, we put it actually in 9 months. I mean, I'm showing you only one of the control. This patient, these 3 mice got only IgG, the sera from the patient. And the 3 mouse here, this is normal colon. There is nothing there, okay? So the mice that got IgG from the patient, keep in mind, this is IgG from patient who had severe colitis, who received anti-PD-1 and had severe colitis. But then when we give the mouse, give him IgG, the mice give them IgG and anti-PD-1, I think you can appreciate that in 2 or 3, there was extensive lymphocyte infiltration. There was extensive, you know, reaction to it. The argument we are making is that, keep in mind, I'm not saying that specific antibodies. What we did is that we got the sera from the patient and you purified the whole IgG and we put it in the mouse. What we are saying that this autoantibodies that is present in the patient's sera contributed, at least in part, to the development of this colitis, okay? And we repeated 3 times and turned to be true. I'm showing this because, you know, the lymphocyte infiltration is kind of clear, but I start learning about this more. It turned that for colitis in mice, loss of globulate cell is considered an inflammatory reaction. Increase in the muscularis mucosa is considered an inflammatory reaction. There are a lot of scales that you can use to determine the inflammatory reaction. In the people who develop these scales are the people working on IBD, inflammatory bowel disease, who work on mouse model. But anyway, this suggested that that the sera and what we are detecting in the sera is contributing to the toxicity. So I'll touch on another thing very short, which is we talk here the thing that I told you about. It was focusing on stage 3 when we know that the chance of recurrence is 50%. Okay, 50%. I don't know, when we tell patients your chance of relapse is 50%. What does this mean? What kind of staging that can be useful if you tell the patient your chance is 50-50? Anyway, so, but what about stage 2? Okay, the question here is, can we prioritize microRNA expression signature in stage 2 that can inform a clinical use for relapse prediction model? We work on a lot of microRNA. Eva Hernando at NYU led this effort. We publish a lot about not only prognostic predictive, but we publish a lot about also their mechanistic role, altered microRNA regulation in melanoma. So in stage 2, the chance of recurrence is around 20%, 25%. So this is not really the, yes, 50%, but it's not only 5 to 10%. So you have 25% of stage 2C, okay, can recur. So the question is, can we identify who will recur? So Eva had this data, this is unpublished data, where she identified with Yang Shao, our lead statistician, a signature of 7 microRNA can predict, as you see, area under the curve, the recurrence-free survival with very few misclassification. And then we use it, David, to convince Merck to give us access to these samples. And the idea is, so Merck is having a clinical trial where in stage 2 disease, where they will compare the placebo, which is the, placebo means nothing, which is the standard of care, and Pembro, okay? So basically what we think is that if we get access, but every patient coming will be randomized. So they don't have any criteria to determine at this point who will get what. And we think that looking at the microRNA signature that we identified in as many as the 954 that they have, actually, David, they said they cannot give us tissue, but they can give us slides. So if you say, I need a slide, or I need, it's easier for them than to say, I need to cut it myself for, okay? But anyway, so basically we think is that in this arm, we will determine the prognostic impact of the signature, because these people, basically, you are watching their natural history of the disease, and this arm will determine its predictive impact. And then basically, I mean, even with this, it will require another study that we will stratify patients based on the data we will have here. So these are the, I described now actually 2 of the SPORE project that we submitted, but in the big scheme of things, the other 2 is microbiota and germline, but all focus on the adjuvant setting. So in conclusion, I think targeted therapy has produced impressive response, but resistance remains a major issue. I think immune checkpoint inhibitor can produce durable response, durable clinical benefit in subtypes of metastatic melanoma patient. Adjuvant immune checkpoint inhibition can prolong survival of patients with stage 3 and maybe stage 2. And that we need clinical tools, not only research tools. We need to think of how can we take this, what does it take to make it to the clinic, not only to get it published, are needed to balance the risk of toxicity versus the risk of relapse, especially in adjuvant setting when toxicities are less acceptable. With that, I want to acknowledge Eva Hernando, who's working on the microRNA and a very important member of the melanoma program, Yang Shao, our lead statistician, Jeff Weber, who joined us a couple of years ago and took the whole program to a different level, Darmin and Keith of my group, Thomas is working on the germline, and Rob and Danny, who help with analyzing the data for the proteomic. This is the picture in New York this summer. Thank you very much for your attention.